I'm Jonathan Mandel. I'm a radiologist and a nuclear physician at St. Joseph's. And Dr. Irina Rachinsky also co-authored this presentation. She's the director of PET-CT in London and the region. I'd like to acknowledge several people who helped, and I apologize in advance if I left somebody out, but John Butler in particular has helped a lot with this presentation, whether he knows it or not. In, I believe, February of this year, we had installed the first PET MRI in Canada. It's a Siemens device named the Siemens Biograph MMR for molecular imaging. It comprised of a state-of-the-art 3 Tesla Siemens MRI, the Vireo model, with a PET component. And it's not actually a sequential imager like our PET CTs are. When you get a PET CT, you have essentially sequential imaging. You have a PET, and then you have a CT, or it could be reversed in that sequence. So the actual image acquisition of the two modalities is not truly simultaneous. In this PET MRI, it is. The PET detectors are fully integrated into the system. It uses a semiconductor detector, which is not unique, but it's very early in development, at least in PET imaging, as opposed to typical photomultiplier tubes, which are used in conventional PET. And this truly simultaneous acquisition, as I said, is unique, and the main advantage is you get fully registered PET and MRI when you acquire the images. We've looked at some of Siemens' analysis, done some analysis of our own, and there doesn't seem to be any significant compromise to either the PET or MR quality. It's a very broad statement, but in various quantitative measures, this seems to be the case. And the main advantage, of course, with MR, there's no CT radiation, and you can do very high resolution, very tailored imaging to specific applications. One of those, for example, in cardiac imaging, you can use MR to apply motion correction to PET imaging, something that would be not easily achievable with CT given the radiation doses. This is just a slide showing some of the quantitative analysis and comparison of, at least in London, Ontario, our GE PET-CT compared to the new Siemens MR. The crystal detector is a similar ASO, whereas, as I mentioned, we use avalanche photodiodes, or a semiconductor-based method of detection rather than the PMT or photomultiplier tube. And spatial resolution on the PET is at least as good, if in fact probably a little bit better, around 4.3 millimeters compared to 5.1 millimeters. And this is using a fluorine PET tracer, FDG. The different tracers you use, if you're using carbon-11 or ammonia or gallium, you will have different resolutions inherent to the positron you're dealing with. The sensitivity of this magnet is 15 kilocounts per second compared to megabecquerel, which is roughly double compared to our baseline PET-CT here in London. This is a comparison of Siemens' state-of-the-art MMR compared to their MCT, their equivalent, and we can see similarly, roughly similar quality measurements in the PET, if not better. One of the problems with PET in general when you're acquiring imaging is attenuation. Just a brief illustration of what is attenuation. When you acquire a raw PET image, the photons are coming out of the patient. The closer those photons are to the center of the patient, the more likely they will get absorbed by the patient as they exit and get detected by the detector, and I'll just briefly illustrate that. If you have an incident positron interacting with one of the patient's electrons, you'll get 2 photons traveling in opposite directions, and if you're lucky, they will both get detected simultaneously. But sometimes those photons can get blocked, and you can look on the image, the more closer you are to the center of the image, the more attenuation you have. In order to correct with this, with PET-CT, you have a built-in anatomic attenuation correction mechanism. That's what a CT is. CT is a measure of X-ray attenuation. So using fancy mathematical processing, you can transform your raw PET image into a more traditional, better quality PET image. And this is necessary for quantitation and simply also for diagnosis. The MR signal is, such a thing as MR signal is quite variable. It depends on what measurement you're measuring. T1 relaxation, diffusion, whatever you're measuring, there's no direct correlation between an MR signal and attenuation of your photons. So this was a problem that we had to solve. Now, those that are familiar with MR know that there is a sequence that we can acquire with a gradient echo T1, taking advantage of the inherent differences in resonant frequency of fat and water. We can acquire sequences that are imaged at a time where fat and water produce an in-phase image where the signal adds together, versus an image that is acquired slightly out, exactly out of phase, where the signal is canceling out, where fat and water are together. And this is known as the two-point Dixon T1 weighted MR, and from that you can derive an image of fat and an image of water, which largely explains the attenuation that you get in the body, different tissue densities from these two substances. So from our water image and our fat image, we can derive an attenuation map in the top right, or you can think of it as a pseudo-CT. On the bottom right, you have your non-attenuated corrected PET, and when you apply your attenuation, similar with CT, you can get your attenuation corrected PET. So this is a bridge to basically taking PET MR and making it mimic PET CT, at least in terms of attenuation. These are some clinical examples of some of the oncologic imaging we've acquired with PET MR to date. This is a patient who had a left leg melanoma resected. Difficult to see here, but on the MR here, this is a T2 weighted image. You can see a low signal mass here, essentially anterior to the left external iliac artery. We can show proper registration with PET MR here. This is an example of a patient with bronchogenic carcinoma, large mass in the right lung, appropriate registration with MR. Similar patient with bronchogenic carcinoma, and if we look additionally, we can see hotspot in the right adrenal gland, a typical location for metastasis for bronchogenic. And just as an interesting example, those that are familiar with MR, we can use the inherent signal characteristics of adrenal-based lesions on MR to help decide whether we're dealing with a benign lesion like an adrenal adenoma, or is this truly a metastasis. One of those clues on MR is between the in-phase and out-of-phase T1. It's a known fact that benign adrenal lesions tend to have some fat, so we expect to see a signal drop-off on the out-of-phase image. But in this case, difficult to see here. This wasn't tailored to acquired, but the signal's increasing on the out-of-phase. It's just concordant with what we're seeing on MR, metastasis. We're performing a number of trials with patients, pilot trials to date. We have a general oncology trial comparing PET-CT and PET-MR for essentially all comers of oncology patients. We're about to start a rectal cancer dedicated project with FDG. And similarly, we have an FDG head and neck cancer project about to be underway. And the main advantage with PET-MR is that the imaging agent is completely unrestricted. We're looking at all positrons are going to emit photons of the same energy because you're looking at the antimatter equivalent, 511 keV. So it's the same photon for all imaging. So you can use any fluorine-based agent, gallium-based agent, carbon, oxygen, anything you want. So we're looking at breast cancer 3TMR using FLT, essentially DNA-based tracer fluorine analog. For prostate in particular, we can acquire a full-fledged, full-quality 3 Tesla MRI. As you've seen, similarly, we can get high-resolution T2 images. This is on our Siemens PET-MR non-endorectal coil image, and the quality is pretty good without the endorectal coil. This is an ADC map. You can do spectroscopy, and all of this is fully registered with the PET. We've imaged one patient so far with PET-MR using fluorocholine as our PET imaging agent. It was part of a trial that's underway in London, which is looking at multimodality imaging for 3D correlation, similar to what we've seen on previous talks today. These patients obtain F-choline PET-CT, CT perfusion imaging, MRI, and then PET MRI has been added as an optional imaging agent, which we're using now. And these patients also get 3D ultrasound and then proceed to radical prostatectomy and then whole mount 3D histology, similar to what we just saw. So this is imaging of our first PET MRI patient using F-choline registered with T2-MR here. Coronal and axial imaging here. From the imaging perspective, this patient happened to be negative, unfortunately. In terms of where we're going in the future with PET-MR, specifically with prostate, the issue with endorectal coil imaging, we would like to do that imaging, but unfortunately, the endorectal coil that's devised for the 3T Siemens system was not designed with PET in mind. And attenuation is one of the issues that we're talking about, and any metal components in a device that are in your imaging field are a big problem for attenuation. They will block the photons. This is on our neighboring system at Robarts. We have a 3T system with GE, and this is just an example on the same patient of a surface coil imaging compared to endorectal coil imaging. And on that machine, the endorectal coil is maybe not essential, but quite helpful in imaging quality. On the Siemens, it is a bit better, but if we want to get optimal imaging like we just described, certainly for research purposes, we'd like to at least try to get endorectal coil images. This is a CT, not of this particular coil, but of a different surface coil, and it's just showing in general these coils have lots of metal components. When the MMR was designed, some of the surface coils were designed specifically to be quote-unquote PET compatible, which really means taking out most of the metal components. So we have a head and neck coil, a spine array coil, and we have our body flex coil arrays as well. If we're going to design a PET compatible coil, we have to basically reduce the electron density, meaning taking out as much metal as possible. And if you can correct for this if you do have a metal object within your MR and PET imaging field. You could correct for that geometry, but you would have to know precisely where that coil is in the imaging. And as we've seen with MR, the endorectal coil itself is not detected. The coil is not going to detect itself. It's also mobile and moving. It'd be very difficult to geometrically compute an attenuation correction. So we're looking for a redesigned coil. In terms of where we're going with prostate, the tracers that we've been using so far are FDG and F-choline. We're producing the FDG right now in London at St. Joe's. The F-choline is also being produced. It's not yet licensed for production, but that hopefully will be coming online soon. But like I said, the PET-MR device itself is not restricted in terms of tracer. Other potential imaging tracers that we could use would be androgen receptor. FDHT is a dihydrotestosterone androgen receptor. There's an fluorine-18 labeled compound that can do that. FLT is fluorine-labeled thymidine, which looks at DNA metabolism in terms of cell proliferation. FMAU is a similar thymidine analog, also existing and under research in the world for prostate. We heard about ghrelin, which is a growth hormone receptor, but interestingly, it looks like prostate cancer also expresses a gastrin receptor for some reason. So a gallium-68 has been labeled to a gastrin receptor binding peptide, another research agent. If any of these could be produced locally or in the region, if we can acquire these tracers, we would be able to image this with MR. This is just an illustration of our cyclotron facility. This is Dr. Kovacs, our cyclotron director. And similar to what's been discussed with Dr. Hayder and some of our other talks as well, the PET MRI is suited for helping to guide biopsies. Dr. Hayder alluded to the Artemis device, which was partially developed here in London. It's essentially a 3D ultrasound-guided biopsy device. This is one of the original prototypes developed here in Robarts. I have performed some of these biopsies, and patients are always a little anxious when you're about to do a prostate biopsy. It's a very weird and uncomfortable procedure, and I can't imagine how they would feel seeing this device. But fortunately, there's a more plasticized version. It's much more elegant and clean, like your computer. It's a little bit more friendly, but the nuts and bolts are essentially identical. And we've discussed using MRI to guide biopsies, using image registration between MR and 3D ultrasound. You can use the information on MR to guide your biopsy. Well, we have PET MR, and we're in a unique situation here, at least in Canada and only a few places in the world, to use fully registered, simultaneously acquired PET MR to guide a 3D ultrasound-guided biopsy. To just use PET images on its own or even PET CT might be a little bit cumbersome, but to have this pre-registration would be very helpful. And this would just be a hypothetical. If this patient had only FDG avidity or only F-choline avidity and nothing on MR, we could still use that PET information to guide biopsy. And I just did a really quick lit search on PET MRI in 2012, and on PubMed, 68 studies already published. So we may be the first in Canada, but certainly a lot of work is going into this over the world. So this will be the up-and-coming technology, I believe. So this is a summary of what we discussed so far. Thank you very much for your time.